Hello, my name is Osama. Naga will discuss in this section Pediatric emergencies. Check the third edition for all updated information. General approach to a child with suspected ingestion, detailed history and physical examination are very important. Suspected ingestion or poisoning in any child with sudden or acute change in mental status, especially if no other explanation. Management always airway, breathing, circulation, especially if the child is mentally depressed, so intubation will be important at this point. Breathing, monitor blood pressure and heart rate. Complete metabolic panel is very helpful to check for hypoglycemia, like in case of ingestion of alcohol in children can be associated with hypoglycemia. Chemistries, renal function, BUN and creatinine. Liver function, like in cases of acetaminophen or Tylenol ingestion. In the first hour, gastrointestinal decontamination is very important with single dose activated charcoal, except a few exceptions here like caustic agents, hydrocarbon, ethanol, methanol, ethylene glycol, metals, iron, cyanide and lithium. So few exceptions, but in most of the cases single dose activated charcoal is very important to administer in the first hour. Very important to know that serum ipecac or induction of vomiting is not recommended and always is the wrong answer. Very important to take a detailed history to have some clues to causative agents from bystanders, family, friends, EMS providers. Very important to ask about all medications at home, medical conditions at home, like if someone with hypertension, someone with depression or ADHD, ingestion time, quantity and co-ingestants. Ask about the name of the medication, concentration, how many milligram in each tablet, and the quantity, how many tablets was ingested or how many tablets in the bottle. Is the bottle is new or old? Very important. Any information is very helpful in the management. If you have a child or teenager presenting with dry mouth, hyperthermia, flushing, agitations, urinary retention, ileus, tachycardia, seizures, or coma, this is anticholinergic ingestion. Possibilities are diphenhydramine or Benadryl overdose, atropine, plants, for example, used in recreational drug like Jimson weed or deadly nightshade. The management here, ABC of course, activated charcoal in the first hour. In severe and persistent cases, the antidote for anticholinergic is physostigmine. If you have a child presenting with lethargy, meiosis, bradycardia, hypotension, or even hypertension or apnea, helpful information from the history. Ask if any home medications, ask about family members with ADHD, tics, Tourette syndrome, hypertension. Any of these conditions, they can use Clonidine, and any amount of Clonidine can be toxic in children and has to be taken seriously. General management is ABC, intubation of respiratory depression. Clonidine can cause serious respiratory depression or apnea. ECG, IV fluid for hypotension, dopamine, and epinephrine if IV fluid fails to correct the low blood pressure. Activated charcoal in the first hour for GI decontamination. Atropine for bradycardia. Naloxone can be used in severe cases. If you have a patient presenting with pinpoint pupil, coma, respiratory depression, this triad suggestive of opioid exposure. It is very important to know that some patients with opioid exposure, they do not present with meiosis or pinpoint pupil. And the most specific sign is respiratory depression in opioid exposure. Opioid exposure can be morphine, heroin, methadone, codeine, meperidine. So the treatment ABC, like any other intoxication, intubation if is necessary, and naloxone as needed, activated charcoal if ingested. If you have a child presenting with hypertension, cogwheel rigidity, CNS depression, dystonic reaction like spasm of the neck, thrusting of the tongue, upward deviation of eyes or oculogyric crisis, the possibilities are promethazine or Phenergan, prochlorperazine or chlorpromazine. Phenergan used as antiemetic. These two agents, they are used for, or they can be used for nausea, vomiting, and psychosis. Metoclopramide, commonly used for GERD, stimulates GI motility, nausea, vomiting. These agents, they have dopamine antagonist D2 receptor, and they can be associated with dystonic reaction. The antidote is diphenhydramine to treat dystonic reaction. Of course, the management ABC, activated charcoal in the first hour for GI decontamination, management of blood pressure. So remember, dystonic reaction, the treatment is diphenhydramine or Benadryl. Acetaminophen or Tylenol is almost available in every home. So very important for us to be familiar with acetaminophen intoxication. Acetaminophen can cause damage to the liver, and early treatment can reverse the toxicity of acetaminophen. Ingestion more than 200 mg per kilo is considered toxic in children. Ingestion more than 7.5 to 10 grams is considered toxic in adults. Generally, more than 150 mg per kilo is considered toxic in children. So acetaminophen can cause elevation of transaminases ALT and AST, prolonged prothrombin time, bilirubin, liver failure, and even death. So very important to know, in the first 24 hours, most of the patients, they do not have symptoms. And this is the time the patient need to be treated the most. So early treatment in the first 8 hours can save the patient's life and the liver. At 24 to 72 hours, the expected abnormalities are elevated liver enzymes, AST, ALT, elevated prothrombin time, bilirubin in severe cases. This is the most dangerous, prothrombin time and bilirubin when they are elevated. Between day 3 and 4, if the patient not treated early, it may develop liver failure and encephalopathy. Between 4 and 14 days, either recovery or death. Management of acetaminophen intoxication using Romac-Matthew nomogram. The y-axis is the level of acetaminophen in blood, and the x-axis is timing in hours from the onset of ingestion. If the level stays at this point, there is no toxicity. When it reaches between these two lines, there is a possible toxicity. When is above this line is probable toxicity and is dangerous. Management is ABC, activated charcoal in the first hour for GI decontamination. Assessment for a possibility of co-ingestant is very important. Measure a 4-hour serum acetaminophen level if you know the time of ingestion. Before 4 hours is not helpful. Admit if the acetaminophen level is above the possible toxicity line. So any level in this region is dangerous. So you have to admit for N-acetylcysteine or mucomist administration. Mucomist or N-acetylcysteine therapy is most effective when initiated within 8 hours of ingestion. Oral formulation of N-acetylcysteine or mucomist, not IV. Oral formulation is the drug of choice. It's a benign medicine to use. For example, if you have a patient presenting to you close to 8 hours or after 8 hours, this medicine is benign. You do not need to wait for the level of acetaminophen level. You go ahead and administer mucomist while you are awaiting for acetaminophen level if there is a potential toxicity with acetaminophen or Tylenol. Start with loading dose 140 mg per kilo, followed by 17 doses, each one is 70 mg per kilo, given every 4 hours over total 72 hours. Indication for transplantation, hopefully not. Metabolic acidosis if it's persistent, renal failure, coagulopathy, or prolonged prothrombin time, or encephalopathy. Ibuprofen ingestion or other NSAID, for example naproxen, usually they will present with abdominal pain, GI bleeding, renal failure, metabolic acidosis. Management is ABC, activated charcoal in the first hour if there is no perforation, normal mental status, and no vomiting. Hemodialysis if it is associated with severe metabolic acidosis. Salicylic acid ingestion or intoxication is classic and is a very high yield. Salicylic acid can be found in anti-diarrheal remedies over the counter like Pepto-Bismol, which is not recommended for children presenting with diarrhea. Also regular aspirin or baby aspirin at home can be seen also in topical agents like keratolytics like water remover and sport creams. The classic presentation is ringing, tinnitus, nausea, vomiting, hyperventilation, respiratory alkalosis, metabolic acidosis, seizures, hyperthermia, coma in severe cases. Ingestion of more than 200 mg per kilogram is toxic. More than 300 mg per kilogram is significantly toxic, and more than 500 mg per kilo is potentially fatal. Management is ABCs, activated charcoal in the first hours for GI decontamination, IV fluids, alkalinization of urine with sodium bicarb to keep the urinary pH more than 7.5. Tricyclic antidepressants ingestion or intoxication, for example amitriptyline. Tricyclic antidepressant, they have anticholinergic action, and they present with delirium, dry mouth, hyperthermia, urinary retention. Also, they have alpha blockade, and they can present with hypotension. Also, they can present with seizure, and they have a membrane stabilizing effect on the myocardium, and they can present with cardiac arrhythmias, widening of QRS, and tachycardia. Tachycardia is the most common presentation. Management ABC is activated charcoal in the first hour. ECG is very important to order for any patient with tricyclic antidepressant ingestion. Sodium bicarb if QRS duration more than 100 milliseconds, ventricular dysrhythmias, or hypotension. Caustic ingestion is serious. Ingestion of even a small amount of acid with pH less than 2 or alkaline with pH more than 12 can cause serious injury and damage to GI tract. The classic presentation: pain, drooling, vomiting, abdominal pain, difficulty in swallowing, refusal to swallow, stridor, or respiratory distress. Very important to know that the patient may have significant esophageal injuries without oral lesion. So absence of oral lesion does not rule out esophageal injuries. Esophageal injuries usually complicate with a stricture of esophagus. Very important to know that emesis and lavage are contraindicated. Endoscopy within 12 to 24 hours in symptomatic patient and GI consult is required. A stricture of esophagus may require repeated dilatation or even surgical correction if repeated dilatation fail to correct the stricture. Organophosphate and insecticide exposure is a high yield. It can be found in any spray for insects and insecticide liquids. The classic presentation, we use the pneumonic dumbbells, which is diarrhea, urination, meiosis, bradycardia, bronchospasm, and cough, emesis, lacrimation, lethargy, salivation, and seizures. The management is ABC, intubation, ventilation if needed. Wash all exposed skin with soap and water. Immediately remove all exposed clothing, fluid, and electrolyte replacement. Very important to know that antidote is atropine and pralidoxine. Hydrocarbon ingestion or inhalation is dangerous and can be associated with serious complications. Examples of hydrocarbon: mineral spirits, kerosene, gasoline, motor oil, turpentine, toluene, spot remover, glue, rubber, cement, solvents, and benzene. Hydrocarbon can affect in organ CNS, lung, kidney, even GI. So hydrocarbon can decrease the lung surfactant in the lung, can be associated with alveolar collapse, pneumonitis, and vascular necrosis. So the presentation can be respiratory distress, cough, pneumonitis. It also can affect the heart. It can cause ventricular arrhythmia, ventricular fibrillation, syncope, and even sudden death. Benzene is well known to affect the blood and can cause aplastic anemia, myelogenous leukemia. The management of hydrocarbon ingestion and inhalation mainly supportive. ABC: ensure airway, breathing, circulation, ventilation if is required, no lavage, no emesis, no activated charcoal. If the patient completely asymptomatic, no cough, no vomiting, no cardiac manifestation, no CNS manifestations, observe the patient at least 6 hours in the ER, and you are able to obtain another X-ray before discharge to ensure there is no aspiration. Very important to know that if the patient develops ventricular arrhythmia or fibrillation, you are able to use lidocaine or beta blockers. It is very important to be able to differentiate between methanol ingestion and the ethylene glycol ingestion or antifreeze. Methanol ingestion affects mainly the eye, ethylene glycol ingestion affects mainly the kidney. General manifestation similar to alcohol ingestion, hypoglycemia, hypothermia. Both of them, they can be associated with metabolic acidosis and high anion gap. Visual disturbance in methanol ingestion and blindness. In cases of ethylene glycol or antifreeze, hypocalcemia, renal failure, deposition of calcium oxalate in the renal tubules, and kidney stones. Both of them, the management is the same: IV fluid, glucose, bicarb as needed for electrolyte imbalance and dehydration. Antidote for both of them is fomepizole, and you can use ethanol if fomepizole is not available in both cases. Carbon monoxide is a colorless, odorless gas produced by incomplete combustion of carbonaceous material. Common sources: charcoal grills, water heaters, running engine in a closed garage. This is a common scenario. Swimming behind a motorboat. This gas can cause a headache, malaise, nausea. As the level increases, it can cause confusion, ataxia, syncope, tachycardia, coma, seizure, myocardial ischemia, acidosis, cardiovascular collapse in severe cases. Investigation or the laboratory of choice is arterial blood gas with CO level or carboxyhemoglobin level. Creatine kinase in severe cases, ECG if cardiac symptoms, management 100% oxygen to enhance elimination of carbon monoxide. Use 100% oxygen until the carbon monoxide level is less than 10% and the symptoms resolve. So you need to do repeated ABG. Hyperbaric oxygen in a hyperbaric chamber if carboxyhemoglobin more than 25%, significant CNS symptoms or cardiac dysfunction. Iron ingestion is common because of widely available multivitamins and oral iron pills at home. Ingestion of more than 60 mg per kilo per dose is toxic. This can be associated with nausea, vomiting, abdominal pain, hematemesis, metabolic acidosis, and GI scarring. Also can cause liver failure. Iron pills commonly seen on X-ray, so abdominal X-ray will be very helpful. Iron blood level more than 500 microgram per deciliter is toxic and is an indication for chelation with IV deferoxamine. Remember, the antidote is deferoxamine. Head trauma with swelling in the frontal area is very common. If there is no loss of consciousness, there is no recurrent vomiting, normal mental status, normal neurological examination, this requires only reassurance. On the other hand, if you have a child with signs of basilar skull fracture like Badel sign or raccoon eye or CSF otorrhea or rhinorrhea, this is a pathognomonic for basilar skull fracture or ocular nerve entrapment. This is serious. This requires CT scan and further care. Eye examination and pupillary size is very important in head trauma and may suggest the level of the injury. If you have unilateral dilated pupil, this indicates cranial nerve 3 compression and the ipsilateral herniation. If you have pinpoint pupils, this indicate pontine lesions. Mid-position non-reactive to light pupils indicate midbrain injury. If you have ipsilateral pupillary constriction, ptosis, and anhidrosis, which is Horner syndrome, this indicate hypothalamic lesion or disruption of sympathetic pathway. If you have nystagmus, this may suggest or indicate cerebellar or vestibular injury. Head trauma can be associated with scalp injury, skull fracture, basilar skull fracture, concussion, contusion or laceration of the brain, intracranial hemorrhage, for example, subarachnoid hemorrhage, epidural hematoma, subdural hematoma, intraventricular hemorrhage, penetrating injuries, diffuse axonal injury. Head CT scan is without contrast for head trauma. Indications for head CT scan: anisocoria, GCS score less than 12, some suggestive is less than 15. Post-traumatic seizures, so seizures after head trauma is an indication for a head CT scan. Amnesia, progressive headache, unreliable history or unreliable examination because of possible alcohol or drug ingestion, loss of consciousness more than 5 minutes. I will correct that in the next edition of Pediatric Board Study Guide. Physical signs of basilar skull fracture, repeated vomiting or vomiting for more than 8 hours after injury, instability after multiple trauma. Lacerations are common in pediatrics. The first step, wound assessment, to assess the severity of the wound and depth of the wound to see if the wound is involving muscle, tendons, nerves, blood vessels, or bone. Very important to know that a wound showing underlying tissue or continue to bleed will need to be repaired. But also, on the other hand, a simple hand laceration less than 2 cm long may heal well with conservative management. Second step is to clean the wound and irrigate the wound with saline or tap water. Avoid using povidone iodine detergents or hydrogen peroxide because they delay the wound healing. Indications for surgical consultations in cases of lacerations: deep wounds of hand or foot, full thickness lacerations of the eyelid, lip, or ears, lacerations involving nerves, arteries, bones, or joints, or severe crush injuries. It is very important to be familiar with the appropriate size sutures. Generally, thin or fine sutures are more cosmetics. For the trunk, or if you have laceration in the trunk, use 3-0 or 4-0. Extremities and scalp, use 4-0 or 5-0. Choose blue color for the scalp, so when you remove the stitches will be easier to identify the sutures. For the face, choose the finest sutures, 5-0 or 6-0 for cosmetic purpose. Removal of sutures, very important for us to be familiar with the timing of removal. For the scalp, about 7 to 10 days. Face, 3 to 5 days is the shortest. Arms, 7 to 10 days. Trunk, legs, hands and feet, about 10 to 14 days. For the palm and soles, they are the longest, 14 to 21 days. It is critical to carefully examine the eye after any head injury, facial trauma or blunt trauma to the eye. One of the complications is blood in the anterior chamber. This is well known as hyphema. Hyphema is dangerous. Why? Because this blood can cause staining of the cornea, can cause scenic eye, increase the intraocular pressure and optic atrophy, and this also can cause vision loss. So pediatric ophthalmology consultation is a must in this case. Management, generally hospitalization of severe cases, bed rest, bilateral patching, topical cycloplegics, topical steroids, systemic steroids, and sedation. Another complication of head injury or facial trauma or eye trauma is orbital fracture. Signs of orbital fracture is black eye, proptosis or bulging eyes, or if the eye is dislocated or is not in normal position, diplopia, limitation of eye movement. This is very important. A change in visual acuity. This is a serious case, requires a CT scan without contrast and ophthalmology consultation as well. Auricular hematoma is considered an emergency because this blood can cause pressure necrosis and damage to the cartilage in the auricle. So it is very important to be drained immediately. Needle aspiration no longer recommended. Why? Because of high rate of reaccumulation. Incision and drainage is preferred. Very important to be familiar with possible complications is reaccumulation of hematoma and subsequent pressure necrosis, site infection, chondritis, scar formation, or cauliflower ear. The pearls here, very important to remember: do not leave an auricular hematoma undrained unless the injury is older than 7 days. Apply a compression dressing rather than a simple dressing. Why? To prevent reaccumulation. Perform daily follow-up ear examination to check for possible complications. After any head injury or facial trauma, we have to examine the nose for any possibility of nasal fracture, for the symmetry of the nasal septum, for any mass in the nostril. If you find a mass in the nostril, bluish or reddish and fluctuant, and the asymmetry of the nasal septum, this is consistent with nasal septal hematoma. Nasal septal hematoma is considered an emergency and has to be drained. Why? Because this can complicate with infection, sinusitis, meningitis, intracranial abscess. If the mass is expanding, this can cause pressure necrosis to the nasal septum and damage and subsequent nasal deformity or saddle nose. Another pediatric emergency, slip decapital femoral epiphysis. This is considered an orthopedic emergency. Why? Because missing this diagnosis in timely manner is disastrous and can be associated with serious complications. Typical presentation is adolescent between 12 and 13 years of age. More than half of the cases they are obese, more than 95th percentile. This means that some cases they are not obese. This is very important. The classic presentation, hip pain, groin pain, this is make it easy to make the diagnosis, but sometimes they present only with knee pain or thigh pain. So if you have a child with a normal exam of the knee, there is no trauma, consider hip pathology, not the knee. So this is make it easy to miss the diagnosis. A patient will hold the hip in external rotation and limited internal rotation. So what to do next? Order AP and frag lateral view X-ray of the pelvis. Immediately non-weight bearing on the affected side using crutches, walkers, or bed rest. Referral to orthopedics for urgent treatment. Animal and human bites can cause bacterial infection, for example, Staphylococcus species, Pasteurella species, Eikenella species. These bacteria can cause tissue cellulitis and even osteomyelitis, like in cases of cat bites. Rabies virus is possible from high-risk animals like rabid dogs or stray dogs, fox, raccoons, and other animals well known to carry rabies. We discussed rabies before in infectious diseases chapter. Drug of choice to protect and prevent tissue infection after human and animal bites, oral augmentin, amoxicillin, and clavulanic acid. Parenteral ampicillin and sulbactam is the drug of choice in severe cases, especially if the patient is hospitalized. If the patient is allergic to penicillin, use clindamycin in combination with trimethoprim and sulfamethoxazole or Bactrim. Snake bites, there are more than 3,000 snake species. Luckily, only 15% of these snakes are dangerous to human. Most of the snakes with diamond-shaped head are dangerous and are venomous. For example, rattlesnake, copperhead snake. Most of the snakes with oval-shaped head, they are not venomous or not dangerous. For example, grass snake, with few exceptions like coral snake with red and yellow kill a fellow. Management of snake bites, like any emergency ABC, ensure airway intubation if is required. Remove any jewelry or constricting clothing from the affected area or extremity. Do not manipulate the wound site. Restrict activity and immobilize the affected area. It is not recommended to incise or cut the site or perform oral suctioning at the site of a snake bite. Admission to the hospital is routine for most envenomation to PICU or ICU. Rule out compartment syndrome. Serial physical examination to make sure the limb or the affected area is not swollen. If it is, you have to consult pediatric orthopedic for measurement of the pressure and management. Fasciotomy can be considered for pressure more than 30 to 40 millimeter of mercury. Antigen binding fragment antivenom is recommended in most of the cases of envenomation. General labs CBC for anemia and hemolysis. CMP to look at the chemistry and kidney function. Peripheral smear. PT, PTT, INR, fibrinogen split products for possibility of associated DIC. UA to look at myoglobin in urine, blood type, and the cross match for possibility of blood transfusion. Chest X-ray for possibility of association of pulmonary edema with a snake bite. Plain X-ray to rule out retained fangs or foreign bodies in the affected area or extremity. The difference between black widow spider bite and brown recluse spider bite is very important, is a high yield. Black widow spider bite is usually painful. Brown recluse spider bite is usually painless in the beginning initially, then becomes painful afterward, and the pain intensifies as the tissue ischemia progress, about 6 to 8 hours later from the bite. Black widow spider bite, more frequent systemic manifestation, for example muscle aches, abdominal pain, hypertension. Brown recluse spider bite is less frequent systemic manifestation, however can be associated with significant systemic manifestations. Local reaction is less in black widow, is more significant in brown recluse, usually start with vesicle surrounding with erythema and can progress to tissue necrosis and induration. Management is almost the same in both, is symptomatic supportive care, provide tetanus if is required, pain medicine, and also antibiotic if the tissue becomes secondary infected. Do not give antibiotic as a prophylaxis, just hold the antibiotic unless if the tissue showing secondary bacterial infection. Status epilepticus means repeated seizures without regaining consciousness between attacks or prolonged seizure for at least 30 minutes. Step number 1, ABC, airway, breathing, circulation. Administer 100% oxygen for all patients who are seizing. Check finger stick for glucose. Hypoglycemia, very important to know, can cause seizure and is very easy to treat. Obtain IV access. Electrolyte imbalance or electrolyte abnormality can cause seizure, like hyponatremia, hypocalcemia. So it is very important to check electrolytes for all patients who are seizing, especially new onset seizure. Complete blood count. Consider toxicology screen. If the patient is having seizure before, check anti-epileptic drug levels, start IV fluids. Continue with management of status epilepticus. The first line and the drug of choice is lorazepam. If you have IV or interosseous access, the dose is 0.05 to 0.1 milligram per kilogram. Repeat the dose if the seizure persists. Lorazepam, it is preferred over diazepam, but consider using rectal diazepam if there is no IV access or interosseous access. If you have IV access or interosseous access, the drug of choice is lorazepam. If the seizure persists after benzodiazepine administration, then give a loading dose of phosphonaitoin 20 milligram per kilo. Very important, while you are giving these medications, you have to continue monitoring the heart and the blood pressure. If the seizure persists after fosfonatoin or phenytoin, consider intubation. Consider loading dose of phenobarb. This is the third drug of choice, phenobarbital. Consider midazolam drip, continuous infusion. Consider phenobarbital drip. Admit the patient to the pediatric intensive care or PICU. Urgent EEG or if possible, continuous EEG monitoring and pediatric neurology consultation. Additional evaluation once the patient is stable can include lumbar puncture if the patient is febrile or infection is suspected, and a neuroimaging study also to rule out any intracranial lesions, especially if new onset seizure. Summary and outline to keep in our mind: ABC in the management of status epilepticus, ABC airway, breathing, circulation. The first drug of choice is lorazepam IV or interosseous. Second drug of choice is fosfonatoin or phenytoin. Very important to know phenytoin can cause low blood pressure. In some institutions, they prefer phenobarb as a second line, especially if neonate or febrile. Phenobarbital is the third. So first line lorazepam, second line fosfonatoin, third line is phenobarbital. Classification of burns: first degree, second degree, and third degree. First degree is painful. The skin is red and dry. Second degree affects partial thickness of the skin. The skin is blistering with fluid in the middle, moist and usually painful. Unless if it's very deep, it might not be painful. Third degree is the most dangerous, most serious, affects the full thickness of the skin and may extend to underlying tissue, muscle, and even bone. The skin will be, or the wound will be discolored from white, tan, brown, or even black, or sometimes red, and usually with no pain. Initial assessment of burns: like any other emergency, airway, breathing, circulation, provide oxygen, intubation if is required, immediate IV access with 1 or 2 large bore catheters, or interosseous access if IV access is not possible for fluid resuscitation. Establish the extent and depth of burn injury, debride any open blisters. The fingers and toes should be wrapped individually and separated with gauzes. Cover all partial thickness wounds with antibiotic ointment. Cleanse minor burns with mild soap and gentle scrubbing. Check tetanus status and provide immunization if is appropriate. If the transport is not immediately available, immerse the burn wound in cold water for about 30 minutes. Cool minor burn under running tap water. Do not use ice water or apply ice directly to the burn wound. This is important. Management of minor burn cases. Superficial burn wound less than 10% of total body surface area can be managed easily as outpatient unless a child abuse is suspected. Before apply any dressing, we need to apply topical antibiotic to prevent the growth of bacteria, for example silver sulfadiazine. This cream can protect against Staph aureus, E. coli, Klebsiella, Pseudomonas, or even Candida. The benefit of applying dressing: this will eliminate air movement and decrease the pain, decrease water loss, and the dressing has to be changed on daily basis. Patients with significant burns would require IV fluid resuscitation. For example, if you have a patient with burns larger than 20% of total body surface area, this patient will require IV fluid resuscitation because of GI ileus. Less than that, less than 20% can be managed with oral and IV fluids. The standard is Parkland formula, which is 4 ml of crystalloid time percent total body surface area burn time body weight in kilograms. The total of that will be divided to 2 halves. First half will be given in the first 8 hours, and the second half will be given in the next 16 hours over total 24 hours. On the second day, you are able to reduce the amount of the fluid by 25 to 50%. It is very important for us to be familiar with burns that is required transfer to a specialized or burn center. Any partial thickness burn more than 20% of total body surface area in a patient of any age, or more than 10% of total body surface area in children less than 10 years of age. Third degree burns covering more than 5% of total body surface area. Second or third degree burns involving critical areas, for example hands, feet, face, perineum, genitalia, or major joints. Burns with associated inhalation injury, electrical or lightning burns, circumferential burns on the extremities or the chest. General manifestations of shock: confusion, fever like in septic shock, chills, anxiety, hypotension, tachypnea, tachycardia, nausea, vomiting, Prolonged capillary refill or poor perfusion, called mottled pallor skin, may be associated with purpura like in cases of meningococcemia. General management of shock position, Trendelenburg position may be helpful. Oxygen, IV access, or interosseous access if IV access is not possible. Fluid resuscitation, the standard is 20 ml per kilo bolus. Crystalloid fluid like normal saline or lactated ringers. If not improving after 2 to 3 boluses, consider packed red blood cells. May use less fluid in cardiogenic shock. Vasopressors if refractory to IV fluids. It is critical to know the normal limit or normal systolic blood pressure according to the age for management of shock. In term neonates less than 30 days old, systolic blood pressure less than 60 millimeter of mercury. Infants between 1 month and 12 months less than 70 millimeter of mercury. Children between 1 and 10 years less than 70 plus the age in years time too. Children older than 10 years if is less than 90 millimeter of mercury. If the patient in cases of shock not responding to IV fluids, vasopressors will be indicated at this point. In cases of warm shock or septic shock, the first line is norepinephrine and of course antibiotics. Normotensive shock, dopamine. Hypotensive shock, epinephrine. If adrenal insufficiency is suspected because fluid refractory and pressure dependent, give IV hydrocortisone. In cases of anaphylaxis, give immediately epinephrine, diphenhydramine or H1 blocker, H2 blockers, for example ranitidine, and steroids. During the process of resuscitation, continuous monitoring is very important. Cardiopulmonary status, temperature status, mental status, urine output, order labs to help with assessment of end organ function, for example CMP, and evaluation of sepsis like CBC and blood culture. Causes of tachycardia with pulse, 4 H's and 4 T's: hypoxemia, hypovolemia, hypothermia, hypo or hyperkalemia, tension, pneumothorax, tamponade or cardiac tamponade, toxins, thromboembolism, and pain. This is an ECG for 12 years old with palpitation. Step number 1 is to look at the rhythm. The rhythm here is regular. Then the next step is to calculate the heart rate. You have here 1.6 large squares, so divide 300 by 1.6 equal 187. Another method, this is a 10 seconds ECG recording. We have here 30 hours, so times 6 equal 180. So 180 is more than the upper limit of sinus tachycardia for this age group. So this is abnormal. This is a tachycardia. Also, there is no variation. There is non-variable rhythm. So there is no variation in the heart rate. Also, if you look here, there is no P wave and the QRS complex is narrow. So this is a case of supraventricular tachycardia. Again, the diagnosis of supraventricular tachycardia if the heart rate more than or equal 180 beats per minute in children, as we saw in the previous case. If the heart rate is more than or equal 220 beats per minute in infants with narrow complex, QRS complex, no P wave, and consistent rate. In this case, perform a vagal maneuver. Do not delay treatment. Adenosine, if the patient is stable, 0.1 milligram per kilo, maximum 6 milligram. And if the initial treatment with adenosine is not successful, increase the dose to 0.2 milligram per kilogram, maximum 12 milligram with rapid push followed by IV flush. Synchronized cardioversion, if the patient is unstable, 0.5 to 1 joule per kilogram, increase to 2 joules per kilogram if not successful. This is an ECG for 6 years old who presented with difficulty breathing. If you analyze the rhythm here, the rhythm is regular. And if you calculate the heart rate, 300 divided by 1.8 large squares is about 166 beats per minute. So this is a case of tachycardia. If you look at here, there is no P wave, plus the QRS complex is bizarre and wide. So this is a case of ventricular tachycardia with unique shark tooth appearance. Management of ventricular tachycardia: identify the underlying cause and treat. If the patient is stable, consider adenosine. If heart rate is regular and monomorphic, amio and broconamide are other options. If the patient is unstable, like cardiovascular compromise, signs of shock, hypotension, change in mental status, synchronize the cardioversion, 0.5 to 1 joule per kilogram, increase if is unsuccessful to 2 joules per kilogram. Torsades point is a ventricular tachycardia with polymorphic complex or polymorphic QRS complexes, and the complexes will be twisting around the isoelectric line up and down, similar to that but wavy. And the treatment for here, if the patient is stable, IV magnesium. If the patient is unstable, defibrillation. Bradycardia generally if the heart rate is less than 60, but this can be normal or non-pathologic in cases of well-conditioned individuals like athletes. Causes of bradycardia may include hypothermia, hypoglycemia, hypoxia, hypothyroidism, electrolyte imbalance, toxic ingestion, head injury with raised intracranial pressure, and sepsis. If you find the PR interval is prolonged in all leads, this is first degree heart block. PR interval more than 95th percentile for age or heart rate, this is first degree heart block. Typically if it's more than 200 milliseconds or 1 large square. This is a 14 years old asymptomatic with cardiac murmur. If we look at the rhythm strip here, the rhythm is regular. The heart rate here divide 300 by 3 equal 100 beats per minute. If you look at the PR interval here is prolonged, is more than 1 large square, is 230 milliseconds, and all P waves successfully conduct to the ventricles. There is no missing QRS. So this is a first degree heart block. Second degree heart block is MOBIDZ 1 or MOBIDZ 2. MOBIDZ 1 or Winkeback, it is a progressive prolongation of PR interval until there is a loss of AV conduction or a loss of the QRS. So progressive prolongation of PR interval until a loss of the AV conduction. If you look in this ECG, you will see the PR interval keep getting longer and longer. And then followed by loss of AV conduction or loss of 1 QRS. We're supposed to have 1 QRS here, but it's not there. So this is an example of a second degree heart block MOBIDZ 1. If the PR interval is normal but periodically there is a drop in QRS, this will be known as second degree heart block MOBIDZ 2. Third degree heart block or complete heart block, no atrial depolarization is conducted through the AV node. So you will see the atrial waves and the QRS complexes are independent. So the P and the QRS have independent but regular or fixed rate. This is an ECG for 2 months old after heart surgery. If you look at the rhythm here, the rhythm looks regular, and the heart rate for this 2 months old, we have 4 large squares between the R's, so 75 beats per minute, which is considered bradycardia for 2 months old. If you look at the P wave here, you will see the P wave in different locations. You have one here, another P wave here, another P wave here on the top or at the end of the T, another P wave here, another P wave in this location. There is no P wave here. So the QRS is independent of the P waves. So this is complete heart block bradycardia with AV dissociation. Management of heart block, observation for first degree heart block and second degree MOBIDZ 1. Management of second degree MOBIDZ 2 and complete heart block in cases of emergency bradycardia, temporary transcutaneous or transvenous pacing is the treatment of choice. Atropine may be used in case of emergency in the first and second degree heart block. Atropine may worsen complete heart block, so choosing atropine for complete heart block is always wrong. So this is a high yield. Permanent pacemaker may be necessary.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.